I'm Alexis Del Cid, and I hope you're all having a wonderful start to 2026. Our team is taking this month to gather phenomenal news stories and topics for our next season of All Things Heart, beginning the first Thursday of February. And we already have some great patients lined up for you, like this Alaska man, Bart Rudolph, who chose to fly from Alaska to the University of Kansas Health System for his open heart surgery because there was no place he trusted more. And then Ryan Azuz, a young man living with an incurable disease who's joined his second clinical trial to help find a cure that could help others in the future. We are excited for what's to come. Until then, please enjoy this Encore presentation. A woman in her 30s, pregnant with her second baby, is unexpectedly diagnosed with heart failure. The steps doctors here at the health system took to safely deliver her baby and save her heart. Good morning, I'm Alexis Del Cid. Thank you for joining us for the season debut of Season 8 of All Things Heart. We are thrilled to be here with you, bringing you incredible patients and fascinating new topics while giving you direct access to our doctors. Now to today's program. Swelling, shortness of breath, and exhaustion. When Jenna Gottschalk felt those things, she chalked it up to being pregnant with her second baby just 2 months after giving birth to her first baby. So who wouldn't feel exhausted? She was stunned to learn she was in heart failure. And the solution would be one that doctors here say is the first of its kind for the health system. To say Jenna Gottschalk and her husband Preston have their hands full would be an understatement.
They were born the same year, so January, December.
Their son Alice Archer is 7 months old.
Should we stand up?
His big brother Easton James is 18 months old.
Can I have a kiss?
In addition to doing all the things new parents do, times 2, Jenna's doing it all with this attached to her.
The controller is in my abdomen right here, and then it goes into my heart. So I literally have a cord hanging out of my stomach.
It's called an LVAD, a left ventricular assist device, and it keeps Jenna's heart beating mechanically.
It's kind of a weird thing to think about. But yeah, so I'm battery powered, basically.
I know a lot more about the heart stuff than I did in December. So.
Yeah. He's a godsend, honestly. I wouldn't have been able to get through this without you.
When they found out they were pregnant with Alice, Easton was only 2 months old. When Jenna struggled with exhaustion and shortness of breath, she thought it was going through a second pregnancy so close to the first.
I mean, why think anything else?
Finally, on December 20th, 2024, 1 week before she was due to give birth to Alice, it came to a head.
We were having dinner. My heart started really feeling like it was beating out of my chest. And I got really dizzy and really lightheaded. And I stood up and I said, that's it. I'm going back to the hospital. There's something wrong.
Jenna was diagnosed with pregnancy-induced heart failure. She was immediately sent to the University of Kansas Health System for an emergency C-section to deliver Alice. Next, she met with cardiologist Dr. Hirik Shah and thoracic surgeon Dr. Matt Danter for a pacemaker and medication regimen.
They're the best, hands down.
But by February of 2025, Jenna's heart was still struggling. They needed a new plan. Instead of putting Jenna on the transplant waiting list, implanting an LVAD as a bridge to transplant, Dr. Danter and Dr. Shah wanted to try something different. What if they used an LVAD to take the pressure off Jenna's heart while it repairs itself?
The end goal is recovery. So it's not a bridge to transplant, hopefully. It's bridge to recovery.
Within days of getting her LVAD, Jenna felt like a new person.
I can breathe, that's kind of fun. I have a lot of energy these days. It's amazing. 1, 2, 3.
And just like everything in their life together, Jenna and Preston are partners in Jenna's recovery.
1 in the morning.
Yes, 1 in the morning.
I have a plethora of medication that I take. That's it. The rest of them are full. And then 3 days a week, I do cardiac rehab.
They also keep a strict heart-healthy diet. Jenna is so grateful for her husband and eternally grateful for the team of doctors that has given her another chance at living the life she dreamed of living.
It's a well-oiled machine. Dr. Shaw and Dr. Dancer, they care for you physically and all that they need to do, but they're also like emotionally there for you. They're always kind of checking in, and yeah, wonderful human beings. They're a part of a spectacular team.
Those are cute little boys,
Yeah.
by the way. I just want to squeeze their little cheeks.
Yeah.
Jenna joins us in the studio today along with one of her doctors here. We have our other doctor in Studio B. We have transplant surgeon Dr. Matt Danter, who is here with us, and Dr. Herrick Shaw, a heart failure and transplantation cardiologist. Thank you both for being here. Dr. Shaw, we know we have limited time with you. You have to go see patients in just a few minutes. So we're going to get to your questions quickly this morning. But first, Jenna, how are you and your sweet little boys doing?
Doing good, doing good. They're very busy, so they are kind of my cardiac rehab.
They are. Yeah, they are part of your physical therapy.
Truly.
Cardiac rehab.
Yeah. Yep.
Dr. Shaw, Jenna just turned 33 last month. That is so young to be diagnosed with heart failure. Could it be from having back-to-back pregnancies?
Yeah, that's a great question. First, Jenna, so good to see you, and I'm glad everything's going well post-surgery, and it's always good to hear the story, and thanks for being such a great patient. So it's a good question. You know, obviously pregnancies. You know, we do know that there is an entity called peripartum cardiomyopathy, where the changes in pregnancy, especially late in pregnancy and early after pregnancy, induces a hormonal change to the body that can, in certain individuals, predispose them to heart disease. And there are some theories behind it where there's some inflammation that can occur, there's some vascular inflammation that can occur. But yes, in this situation, I do believe that this condition was what we call peripartum cardiomyopathy, which is a diagnosis that we see and can treat.
Dr. Danter, you're also, buckle up, this is a long title. You are the Surgical Director of Cardiac Transplantation and Mechanical Circulatory Support. I said it right.
For today, yeah.
For today, and also a television extraordinaire. Why and how can pregnancy put this added stress on the women? Do you see this often as well?
Often would be a bit of a stretch, I think. It is a known entity, and there's a lot of changes that occur during pregnancy, increase in total blood volume, but really it's an as yet sort of diagnosed or as undescribed pathophysiology for sure that leads to heart failure peripartum. But it is one, unfortunately in young women, it's one of the entities that we see not infrequently. Often would be a bit of a stretch, but several times a year we'll see someone in a similar situation, and it's really about Jenna and her husband have managed this extremely well, but it's, as you can imagine, it's a huge stress on top of having a fresh new baby, or in Jenna's case, two. You've also then got to make some very challenging decisions about what your next steps in terms of your care are.
One of the things that was striking when we were going through our interview with you is just the bond you have with your husband, Preston, and what a team you are. Seeing him help you set out your pills. Yeah. Could you have done this without him?
No.
He's even here with you in our control room.
Yes,
he's a big fan.
Yeah, he drives me to and from appointments. I mean, he does my dressing changes. He helps me organize the pills so we don't miss anything and we don't double up on anything. You
can't do that alone.
No, absolutely not.
Do you remember what you first thought when you heard the words heart failure?
Besides, the ringing in my ears, once that stopped and I could gather my thoughts, I just thought, but I don't want to die.
Yeah.
I want to see my boys grow up. I just got them. I want to be there for them. Yeah.
Just like getting hit in the face with something like that. Mm-hmm. Dr. Shaw, we know that shortness of breath can happen with perfectly healthy women who are pregnant. I've heard my girlfriends say that all the time when they were pregnant with their first babies. Oh, I can't breathe, I'm having trouble. So for the pregnant women watching, how would they know the difference between shortness of breath that's typical and heart failure?
Yeah, and I think that's a great question. I think it's not as easy as as you mentioned before. In pregnancy, many people have shortness of breath. We do know that the body's trying to provide for two, and so there's an increase in blood volume, and so you're going to feel things like swelling. You're going to feel things like when you walk around, you're going to feel short of breath, and it's really trying to gauge, how more short of breath are you than you would typically expect. And I think that's why it's really, really important to be honest with your OB, who have really, hopefully, good connections with cardiologists, and getting labs oftenly checked. And if the shortness of breath is, beyond where they're getting short of breath with just very minimal distances, or that swelling is becoming progressively worse. This usually gets worse as the pregnancy progresses. It's probably, the worst the month before pregnancy, and actually very common after pregnancy. And so peripartum can happen kind of at the very end and at the very early stages after pregnancy. So I think it's just being honest with the symptoms, and if anyone has any symptoms, you're like, this just feels abnormal, there's no harm to go and talk to your doctor about it. Because in the end, it's a really easy test to rule out. It's an echocardiogram, and if the echo looks normal, then the heart is doing okay, and we know that it's not the diagnosis. But if the heart is abnormal, the earlier we can know about it and treat it, the better the outcomes are going to be.
While we have you, Dr. Shah, I want to ask you about this recent study that was published in the Journal of American College of Cardiology. It shows the number of women who died from heart issues during pregnancy more than doubled in America from 1999 to 2022. Now, we can see the big spike happened during the first couple of years of the pandemic. Was COVID the main reason for that bump?
Yeah, I would just be speculating. I'm not sure if COVID was the reason for that bump, but it's hard to know.
Do you think that more women who were pregnant at that time avoided doctor's appointments or skipped appointments because they were afraid of catching COVID? Have you seen that now that we're out of the tunnel?
Yeah, it'd be interesting to see how that trajectory trends, but I do agree it's one of those situations where I think many times some people may not feel like it's just normal part of the end of pregnancy or kind of the beginning of the postpartum stages. And so it could be related to that, but I'm hoping that those trends kind of downtrend as, we're farther away from the pandemic.
Dr. Danter, what are your thoughts on that?
I think that in circumstances where you're having to avoid, seeing your physicians or meeting in person it's really an issue of access to healthcare. Mm-hmm. So in circumstances like a pandemic, I think you're going to see increases in many of the sort of diseases of good primary care and diseases of or complications related to not being able to have ready access to the healthcare system. Everybody was avoiding everything during those first couple of years, so it's hard to know whether that's, the timing is suspicious for it being related to more, I'm not certain if it was COVID itself, but more sort of avoidance of access to healthcare.
Right, which would make sense. Jenna, your first baby, what year did you give birth to Easton?
2024.
Okay, so you were out of the worst of the pandemic. Did any of those lingering worries affect you during your pregnancies, worried about catching COVID or being exposed or anything?
Oh, yes. Yeah, I didn't go anywhere for, just being pregnant in kind of cold and flu season. Mm-hmm. I don't usually get flu shots. I got a flu shot, and I kind of avoided social situations.
Did you notice when we're talking about typical symptoms when you're pregnant versus the heart failure and the shortness of breath, with your first baby, did you have the shortness of breath as well, or was this a totally new symptom with your second baby?
It was totally new.
So you knew it wasn't typical.
Yeah, and I just thought, he's up higher, he must be kicking my lungs, and no,
Well, thank goodness that you went to the doctor and you went to the emergency department. Yeah. We love when we get viewer questions. Your questions are the heartbeat of our shows, and we love connecting with you. So if you have a question or a comment that you would like us to read out loud on the program today, just send it to us on YouTube, Facebook, or the All Things Heart email. You can see all the links, how you can connect with us in real time right here on your screen. Dr. Shah, we have one more question before you go, then we can press the eject button and you can get back to your patients. How does it change your treatment plan when you have a patient who's not only in heart failure, but recovering from a C-section?
Yeah, that's That's a very good question again, and it's complicated because there's multiple different factors going on. You know, I think there's the one factor that the body is going through changes from an operation, and there's also the entity that we have to talk about is, you know, you're still in the postpartum stages. Like, are the medicines that we give for heart failure going to be compatible with the postpartum stage? And so, you know, I can just speak to Jenna's case. You know, when she had the C-section, the initial plan was to see if we could start her on medical therapy to help recover the heart. The hope was, we knew the heart was very sick at that point, but the hope was to avoid another surgery right away, the LVAD or a heart transplant right away. And we do know that peripartum cardiomyopathy is one of those entities that does have a chance to recover. I'm sure you guys will go over that. It's one of the higher incidences of recovery. And so the hope was that we would, with medicines, try to get her to a point of recovery. But in this case, it was able to buy her time a few months, you know, after. And then you're further away from the C-section surgery. Everything's already healed. And so your body's probably more willing and more able to handle another major surgery. So basically in this situation is we tried to do what we could with medicines, but then also rechecking the heart constantly. And if the heart wasn't responding the way we wanted it to, then we moved on to the second, you know, heart operation. And that's how we approached this case.
Dr. Shaw, thank you so much for making the time to join us this morning. We're going to let you get back to seeing patients, but we're so lucky that we have doctors that are willing to take the time to join us and share their expertise. Your patients are lucky. Have a great day, Dr. Shaw.
I appreciate and good to see you guys. Thank you.
You too. Okay, so Jenna, first of all, I'm trying to wrap my mind around your emotions.
Yes.
There's all the hormones of pregnancy, then another pregnancy, then you find out you have an emergency C-section, heart failure. Mentally, how were you doing through all this?
You know, I was better than I thought I was going to be for a while. And then even after the LVAD surgery, I think it kind of hit me and I began to feel all those emotions that I kind of wasn't letting myself feel right as it was happening. It's definitely something that I've relied on my family for, and yeah, I still sometimes wake up and go, nah, that didn't happen. Like that wasn't, and then I'm plugged into the wall.
Right.
Oh wait, hold on.
It did happen.
It did, yeah.
I want to talk about the plugged into the wall aspect,
Yes.
the mechanical and medical aspect. And LVAD, for people who aren't familiar, stands for Left Ventricular Assist Device. For viewers who aren't familiar with this, it's a small machine that's implanted in Jenna's heart. It helps pump blood, and it's often called a bridge to transplant because it's what keeps people alive while they wait for their new hearts. But Dr. Dancer, in Jenna's case, you're calling it a bridge to recovery. And this is incredibly rare.
Yeah, bridge to recovery is, there's sort of designations, and they're largely for sort of, you know, data analysis and following people. But bridge to recovery is you intentionally implant the device with the hope that you're going to follow the patient afterwards and their heart will recover. And as Dr. Shaw alluded to, there are certain disease entities leading to heart failure that are more likely to have an opportunity to recover. Still, true recovery to explant only happens about 5 to 10% of the time. But it's something that if you're not looking for it, you're never going to find it. So we're in a different sort of paradigm now when we're looking at what are the goals of heart failure surgery. You know, historically it's been keep people alive long enough to get to transplant or to get to another device, but now with the technology that we have, the outcomes for people under age 50 with an LVAD are so good that in a recent trial they rival survival at 2 years for transplant. And in patients under age 50, the outcomes are so good that you can really start to talk about the philosophy of trying to get the maximum number of years saved, the maximum amount of time for people, because you know transplant is the gold standard and it's fantastic, but it comes with its own set of problems and you know more medications and sort of. In younger people, you're looking at several transplants down the road of their life if our goal is, you know, normal life expectancy. So in this circumstance, we had a disease entity that was more likely to recover than some others.
Because it was
Because it's
pregnancy-induced.
peripartum cardiomyopathy. And then also, comfort in knowing that with the program here and with the outcomes for LVAD therapy, we felt comfortable doing this as a bridge to recovery. But also, if say we're not able to recover, then we still have a very stable platform, relatively free of complications that gets us further out from surgery. It just gives more time on that support before we start talking about transplant options. So,
what is it about the technology that has made this so much more possible than it was 30 years ago?
Well, we didn't have HeartMate 3 30 years ago.
HeartMate 3 is the
LVAD itself. So it has become it's not just one thing. Our program is very comfortable taking care of very sick people. The technology we have is very durable, very stable. The surgical ICU care and then the follow-up afterwards is very sort of stable. We don't talk about being routine, but it is a very well-described process from evaluation of heart failure to management in the outpatient setting and everything that happens in between. So we have a technology that's durable, we have a program and a system that can support very, very sick people, and we have evidence that our outcomes are very, very good, particularly for young people undergoing LVAD therapy.
Your confidence must be reassuring. Jenna, it must be reassuring.
Yeah,
when you
this
hear
feels
guy
good
talk.
to
Yeah.
sit down and talk to them about.
Yeah, well, I've said before, in heart failure, we always have a plan A and a plan B and a plan C. So, it's not like if Jenna's heart doesn't recover, we don't have further options.
Right.
You know what I mean? So
Yeah.
that's the.
But your
That's
first choice is it recovering.
That would
And
be
it can
fantastic. Yeah.
Jenna, can you just show us where, you wear this on it looks like a fanny pack.
Yes. Yeah.
Does it feel cumbersome to wear that every day, or are you used to it?
Some days I don't really notice it, and some days I'm a pack mule. I mean, it's
Yeah.
I have batteries, and it kind of comes out of my abdomen. You can actually feel it kind of all the way up into my chest.
Into your chest. So it's a
Yeah.
big tube. I've seen these sort of described for viewers, 'cause I'm sure you don't feel like lifting your shirt up. But it's a big tube that goes into her side, and then it goes all the way up to her heart. Yeah. You were wearing a shirt that said "No pulse, no problem."
Yeah.
Because if you ever put your ear up to someone who has an LVAD, it sounds like this mechanical whirring
Yes.
sound.
Yeah, it's a hum.
No more
definitely.
heartbeat.
Right.
Do your kids ever get curious and are they old enough to
Not yet.
look for that?
No.
How old is your oldest one?
He's a year and a half.
Okay.
So.
We saw in that video you take several medications that your husband
yes.
Preston helps you with.
Yeah.
Ballpark guess, how many meds are you taking every day or every week?
Every day, I would say, I think I take somewhere near 11 or 15
Throughout the day.
throughout the day. Yeah.
Do you know, what tests do you do to know if Jenna's heart is repairing itself? Is it actively repairing itself now because it's able to rest because the LVAD is doing the work?
That's the theory. So is that the LVAD takes over a significant amount of the work of the heart, and then it's allowed to repair from and recover from whatever hormonal or inflammatory insult led to being impaired. And then basically the surveillance is, like we said, if you're not looking for it, you're never going to find recovery. So what we do is we serially look at echocardiograms and and then we meet and discuss at least sort of once a month the patients who are looking to progress or how they're recovering, and then we at our last meeting we discussed we're going to try and increase some goal-directed medical therapy to try and see if that improves her heart function, but mostly it's serial echocardiographic examination.
When it comes time to, God willing, do the explant process, which explant means you're taking the LVAD out, right?
Yes, if we're not going to transplant at that time, it means that you take out the LVAD itself, get rid of as much foreign material as you can, and then plug the hole in the apex.
That was my question, is we've seen heart transplant surgeries, which are really cool if you're being allowed in, which we are, to those surgeries. I've never seen a explant surgery. Do you ever leave part of it in there, or do you take it all out?
Well, there's a series of things that have to go or have to be sort of developed. One is we can make a custom plug for the area, or we can sort of close it as we used to do for the transapical TAVRs. But basically, we take the whole pump out, the pump chassis, the drive line, portions of the outflow graft, and all of the foreign material, just for future infectious complications. And then we have to plug the hole in the apex with either a custom designed felt plug, or they're developing plugs that you can insert into the sewing ring and block that up.
That's so interesting. And the fact that they're actually now developing plugs shows how it's a possibility that wasn't there before.
Correct. And like I said, this is our first instance of intentionally trying to look for recovery.
The first at the health system
first
that
at
you've
the
ever
health
had.
system, yeah.
What's that feel like?
You know, I didn't know it till now, and wow.
I mean,
Special.
The mechanism is still the same. It's just, you know, with how you present it and with what what we think the underlying diagnosis is. We're very hopeful that we can get there.
We have some great questions and comments coming in, so I want to get to our community questions. Gene Reardon asks, how does the heart recover? He's referring to a patient receiving the LVAD. So how is it recovering?
Well, the theory is that when you take away the stress of having to pump against systemic pressures with the LVAD, that whatever process is going on in the muscle itself or in the sort of physiology of someone in heart failure is reduced to a level that your body can repair itself. Because as we mentioned before, the specific hormonal mechanisms and the specific inflammatory mechanisms that lead to heart failure in the peripartum are not absolutely and clearly defined. So it's just looking at sort of the population health and the sort of natural history of peripartum cardiomyopathy. It's in that disease category where it has a reasonable chance of recovery, and that's why this strategy was employed.
Jenna, Jeremy Yenser has a question. Is there anything you've been told to watch out for in future pregnancies? And kudos to you, Jenna, for navigating all of this at once. That's a lot. You got this. Okay, is future pregnancies in your mind at all?
No. No, yeah. I've been told that it actually gets worse with each pregnancy.
Okay.
So that is not an option for me.
Do you remember feeling any sort of way with your first pregnancy, looking back, thinking, oh, maybe that was the beginnings?
I don't. Yeah. I honestly, until I had was well on my way in my second pregnancy, I didn't feel anything that was out of the ordinary.
Becca has a great question. Becca writes, how do you carry around two babies with an LVAD attached to you? Do they ever pull on the cord?
Yes.
Wow. So what is that? I mean, because I couldn't even wear earrings when I had my baby.
Yeah,
he was a little one.
It's so it's foot level if you're holding one, both my kids actually at this point. So they'll kick it, they'll accidentally get, kind of tangled. It's all about where you anchor it. So they have anchors. So it's not just.
What do you mean anchored? Like taped or stitched?
Exactly, taped.
So have you ever had a close call where one has really pulled on it?
Yes.
Any mom knows this. They have these strong grips and they will pull.
Yes, and at that age, 1.5 and 8 months, they love to start feeling the world. So yes, there's actually been, I think, a couple times that I've had to take antibiotics because it pulled enough that there was risk of infection.
Oh my gosh.
Yeah.
And so do you feel like you now have it under control, or are you still learning as we go?
I think there's always an aspect of learning as we go. I don't think I'll ever know everything, but I definitely feel more comfortable and confident with the care and where to anchor, and okay, so we're doing this today, so I'm going to wear it on my back, and it's.
Well, thank you for getting up early with two little ones at home. That's just making it out of the house on any given day with two little ones is a lot. You were able to come here, get here with all your gear, and then you're on television. So thank you for coming here. I know that took a lot. Yeah. It's time to wrap up with some final thoughts from our guests. So Jenna, before we get to your final thoughts, I do want to share something that you said during our first interview with you.
It's a reminder of life is short. We are here but a moment. And tell the people you love that you love them. Hug them.
Has that mindset changed your everyday interactions?
Yes. Yes, for me, I'm more intentional with my interactions, and I feel like I have more grace for people because I would like people to have more grace for me when I'm having my bad days. And yeah, I definitely think that I've been talking to more people that I maybe don't talk to all the time, and checking in with people, and I just more intentional in communicating how I feel about them. So
what a gift that you've gotten from this experience that has been very stressful and scary. Yeah. Dr. Danter, do you have any final thoughts you'd like to share with Jenna or our viewers?
Well, no, just, try to reassure you that we're here for you for this whole sort of evolution, and for whatever you need, we'll do everything we can to get to where we want to get to. And I think your story is a fantastic one, and very grateful to be a part of it.
You're a strong person surrounded by gifted doctors and surgeons.
An amazing team.